All right, we are just a minute past 8, so we should get going. Happy New Year, everyone, and to the first nephrology grand rounds of 2026. We are really excited to have Dr. Mallika Mendu from Boston presenting to us on optimizing kidney care population health and quality. Dr. Mendu is at Mass General Brigham and Harvard Medical School. She's a clinical expert, innovator, researcher, administrator who deals in the field of population health care delivery, innovation, and clinical operations, which is what she'll be talking about today. She's the Chief Population Health Officer and VP at MGB. And apart from that, she is still a practicing clinical nephrologist. I'm told she's got a clinic in a few hours or in a few minutes after the rounds finish. And she's published more than 90 peer-reviewed manuscripts and also is an associate prof of medicine at the Harvard Medical School. Welcome.
Thank you so much, and good morning to all of you. It's wonderful to be here. As Swapnil mentioned, I'm Mallika Mendu, nephrologist, chief pop health officer here at Mass General Brigham, and I'm here today to present on our work related to kidney care, population health, and quality. I have no relevant disclosures. You'll see here our learning objectives. Objective number one is to give some background on our U.S. kidney care policy, some of our kidney care models and health system efforts. And you'll see, because we don't have a single payer system in the United States, just how complicated our policy is in kidney care. But I think that background is relevant because the landscape is so complex, it has actually spurred innovation related to population health and quality. And there may be some lessons for all of you in Canada to glean from. Second, we'll review a comprehensive framework for kidney care population health. This is a framework that we published about a decade ago now. And you'll see from that how we then utilize a number of population health strategies locally and then with other organizations to facilitate kidney care quality. And then finally, we'll specifically review an advanced chronic kidney disease program that we've established in the last year. And actually will probably resonate with a number of you because we modeled this program after published studies, for example, in Canada and others, other organizations, to be able to create a more holistic support structure for patients with advanced CKD. So these images represent kind of the evolution of kidney care policy in the United States. As some of you may know, at the University of Washington, there was great strides in terms of developing dialysis technology. At the same time, there were similar evolution at Brigham and Women's hospital that I practice in. And really around the same time, there was this evolution of initially largely hospital-based, then actually home-based technologies. But because we did not have a universal healthcare system, the way that the decision about who got dialysis was adjudicated was by these panels. So you can see this picture in the middle here. This is literally the picture of one of the panels in Seattle that made the decision of who got dialysis and who didn't. And then it was the Nixon administration in the 70s that decided that dialysis would be part of the Medicare program. So Medicare is the universal healthcare program for seniors. So we do have a universal program for seniors. So all seniors over the age of 65 are guaranteed healthcare coverage, as well as patients who have ESRD. And so that is why we have had a lot of scrutiny around our ESRD programs because that is paid for by the government. We then had a prospective payment system implemented to help, frankly, curtail costs, but also have a focus on quality. So there's a quality incentive program as well. And then it was the Trump administration that signed an executive order titled the Advancing American Kidney Health Initiative. And so why that is in particular relevant, I'd say, to this discussion and all of you in Canada is that what that has then focused us on in 2019 is when it was signed is a couple of different goals. One is to really advance the uptake of home dialysis in a way that we have been lagging in the United States compared to Canada, compared to other countries, developed countries. And second, a focus on upstream therapy. So SGLT2 inhibitors, for example, are referenced in the Advancing American Kidney Health Initiative. And so the US government made real strides to really focus on kidney disease and say, these are a couple of our goals. We want to slow kidney CKD progression. We want to focus on home dialysis. And also a third goal was to improve transplantation risks shifts. And so that led to these payment models. I won't go into too much detail here around the nuances of these models, but the high level here to understand is the government then implemented both a mandatory model, so that's what's at top here, called ESRD treatment choices, and then an optional model, that's what's below, where nephrologist kidney care organizations could choose to participate in these more advanced CKD related models. The mandatory model basically paid organizations, dialysis organizations, nephrologists to improve their rates of home dialysis and transplantation. And then the optional model provided incentives to prevent crash starts into dialysis, to improve the utilization of home dialysis, and there are actually bonuses paid out when patients were successfully transplanted. So really interesting payment mechanisms. And then this slide just articulates who participated in the KCC model. So those are the optional model. You can see that there was a fair amount of participation by nephrology providers. So 291 professionals joined these optional models, 133 transplant providers, and really spanned a number of states, most of our states, in fact, 33 states, Washington, D.C. So this just shows that there really has been interest in improving care delivery, recognition that our current state just is not serving patients the way it needs to, and that we can do more in terms of upstream screening of patients and identifying opportunities to ship patients to home and transplant. And you can see some of the reasons that the nephrologists indicated that they wanted to participate in the KCF or CKCC, which is just a more global, where you're at financial risk across the whole population. And you can see here this real belief in value-based care, this desire to improve patient care, the belief that value-based care is actually the future of kidney care, and so on and so forth. So a real belief in this shift towards value-based care. And so these are some of the outcomes from that optional kidney care first model, which is that there was an increase in home dialysis utilization, particularly peritoneal dialysis. Training increased 32%. There was a decrease in in-center dialysis as a result of that. There was an increase in kidney transplant waitlisting. We did not see an impact on hospitalizations, ED visits, or readmissions, and we did not see a total impact on total cost of care. And so this is only for the first year. The model extends for 3 years. And so folks like me in this space, I'm also chair of the ASN Quality Committee. We are really encouraging CMS to give this program the full duration of the 3 years and look at not just short-term costs, but also long-term costs, knowing that with the uptake of home dialysis, getting more patients transplanted will in the long run improve patient outcomes and lower costs. And then finally, related to quality of care, there was an increase in optimal starts, decrease in AV fistula use, increase in AV graft use. And I was part of this group. You can see the author list here of nephrologists who were interested in these models before they launched to talk about how we actually implement this type of care, what's necessary to really drive up home dialysis, to foster transplant. And so what we aim to do is to say, okay, if we look at just home dialysis, what are the primary drivers that actually can facilitate shifts to home dialysis. What are the secondary drivers? And even getting into some of the operational details here. Well, there needs to be clinic space for training. There needs to be the right surgical workforce with the experience to place peritoneal dialysis catheters or AV fistulas if for home hemo. And then we talked about here are some of the change ideas and interventions. So I share this to say that this is the type of planning that went into how to be successful in a model like KCF. And then this was similar mapping that was done related to transplantation, time to wait list, insurance coverage. All of these factors are relevant to be able to make strides in this area and really improve outcomes. So finally, I'll end on this slide and then transition to the framework. In the United States, there continues to be real interest in actually shifting to mandatory models, whether it's surgical models. So that was just announced, and we're actually in a surgical model right now, starting this January, where hospitals like our own hospitals here at MGB are facing significant upside or downside based on how we optimize care for patients across surgical models. So we're looking at pre-op optimization during the episode and then post-op. And then similarly, we have ambulatory specialty models related to heart failure and low back pain that are emerging again to come up with these collaborative care models to really optimize outcomes. So there is a real shift in the United States. And so even before that, we were thinking about this in our own group about how do we really optimize care for a population of patients. And what I mean by that is the work that we all do every day with our patients is so important, that one-to-one connection, improving care one patient at a time. But being able to really impact at a population health level, particularly for our patients with CKD and ESRD, really can drive outcomes in a much more effective and efficient way sometimes. And, you know, we have the benefit because we are nephrologists and we have CKD as a condition that is lab-based, of being able to create things like registries, to be able to leverage our EHR in a way that is unique from other specialties. And so, you know, about a decade ago, we were thinking along these lines of how can you start optimizing care across a population? So that is what we put together and published in AJKD, which is this comprehensive approach to population health. And what we did is we broke down care at various stages within the care spectrum. So chronic kidney disease recognition, diagnosis, stemming CKD progression, treating complications, renal replacement therapy preparation, ESRD, of course, and then finally, what we need throughout the care spectrum. At the time we published this study, we did not have SGLT2 inhibitors, so that's why they're not included, but we would definitely include that today. And what we then tried to say is, okay, if we say these are this is kind of the optimal, what we want to appreciate in each of these stages within the care spectrum, then what are some proposed initiatives that would match those ideal states? So, you know, I'll take one stage like CKD recognition. We want to make sure that we can identify all of our patients based on the electronic health record, and that we're initiating appropriate treatment early, leveraging e-consults, which we've been able to expand here, and has been a good tool for patients who maybe don't need to come see us in person. And so if we were to do that, we would then have EHR-based referral alerts, we would have e-consults within that electronic health record, et cetera. And similarly, you know, you can go down the care spectrum and see for each of these stages what we proposed. A registry for patients who have chronic kidney disease and we're worried about progression and we want to monitor the quality of care that they're getting, so on and so forth. And so if we're able to do that, and this is a more recent slide that we've been working on as a population health team, this is what we hope to achieve. The traditional way of caring for patients is really along this red line, which is a patient has hypertension that then evolves to heart failure, then they have an event like a heart attack. And then we enroll them in some type of care management program. We work to improve their utilization, their outcomes. We have some effect on that. But what we want to move down to is when a patient develops hypertension, we in real time identify hypertension wherever they're getting their care. Maybe it's in a surgical clinic, with a specialty group that doesn't typically manage hypertension. Through our EHR, we now have the capability, all of us, because we're all on electronic health records, to identify the hypertension in real time. And then what we've started here is virtual programs to be able to say, oh, this patient has hypertension. Let's at least check in with them. Let's give them a call. Let's make sure they have a blood pressure cuff. Let's take some home recordings. And if they develop hypertension, then we actively manage hypertension with a pharmacist-led program supported by a physician who's overseeing an algorithm that they manage. And then they may still develop cardiac kidney metabolic disease. But if they do, we are aggressively managing that with guideline-directed medical therapy. And the hope here is they may still decompensate, they may still develop heart failure or have advanced CKD, but hopefully during this time we will have reduced the utilization, we will improve their clinical outcomes, and in some cases we might be able to significantly prevent the emergence of these chronic conditions. And so this slide, we're sharing quite a bit to be able to articulate what this means for patients, for a given patient. So now I'm going to get into some of the tools and the initiatives that we've launched here at Mass General Brigham. Other organizations have launched as well that really facilitate value-based care and population health level efforts. So the first is the electronic health record, and I can't emphasize enough how important it is to have these robust EHRs. So it starts with data analytics and reporting. For us in the United States, this is a major issue because we have so many payers, and so being able to attribute the right patient to the practice of the payer is an issue. I'm sure not as much of an issue for all of you with the single payer system. But that is really foundational. But whether it's, practice to provider, that is also important, making sure we have attributed the right patient to the right place that they're getting care. Then what's equally important is that we're capturing the right diagnoses, whether that be medical diagnoses, social diagnoses, etc. It allows us to refer the patients for the right level of care. And so CKD is a great example of that, in which because we have patients who are primarily taken care of by primary care, if they are not documenting, if they're not identifying that patients have chronic kidney disease and are not referring to us in a timely way, we are not going to be able to appropriately manage them. And so that's why this concept of risk capture, which is the complexity of patients, is so important. Ensuring that our EHR has patient engagement tools, that we're using it to really optimize provider workflows. So we need to see our EHRs as tools to make care easier for our providers, not introduce additional burden and complexity. And so we worked really hard with the EHR vendor we use, which is Epic, to think about workflows, to think about how to make this easier for our providers to alleviate burden and gain efficiencies ideally. And AI is going to be a big part of that. And we're just starting the journey with our vendor around what AI means in the space of population health. And then finally, the actual population health management tools. So programs like e-consults or best practice alerts that indicate that a patient should be referred, those can all be enabled within the EHR. I'll just briefly touch upon this. This is just related to our risk capture efforts. A lot of work that we've done to really be able to enable the recapture of conditions, suspect conditions, be able to then generate reports for our providers so that they know which conditions their patients have. And then there's work that we're doing to make this simpler for our providers. We have coders who curate what we call best practice alerts to say to me as a provider, for example, Mallika, your patient has advanced CKD, a CKD stage 4, and nephrolithiasis based on our review of the chart. Adjudicate that. Is that correct? Is that incorrect? And that helps us keep our problem list clean and accurate over time. This is a patient engagement tool that we actually a couple of different patient engagement tools that we launched within our EHR. The first is with the vendor HealthWise, which created for us 4 different tools for our patients that we're able to actually prescribe to our patients. This is for patients who we've had a discussion already about the fact that they have kidney failure, for example, and that they may need to start dialysis, and we can give them this tool that they can go through, and it's an interactive questionnaire, and it helps ask questions about their goals and what they're looking for, and it helps guide our conversation towards home dialysis, for example. And it basically ascertains their goals and what our recommendations are related to initiating dialysis. So it's a shared decision-making tool. We also launched CKD, what we call video scripts, which give very basic information to our patients about what chronic kidney disease is. I'm sure you encounter every day patients being like, I didn't know I had chronic kidney disease. I've had it for a while. What does that even mean? And so we're able to prescribe these videos that go into basic information about what the kidneys do, what the mechanism is, what symptoms patients may expect to appreciate if they have advanced disease, but that for early disease, there really typically aren't symptoms. So we go into very basic detail for patients so that that can help support our visits with the patients. And then finally, we launched chronic kidney disease PROMs, and we published a study on this a couple of years ago, looking at CKD PROMs and how they've been used in our clinics. Basically, we took the SF-36 and we modified that to include questions about kidney disease. And we've been finding that our patients appreciate answering these questions. We've been able to leverage the prompts, and it's already filled out with our first visit with patients, and we're able to look at their answers in terms of the kidney disease and how it impacts their life. And so there's more work we need to do here to think about how best to utilize PROMs, and in particular, the association between PROM scores and clinical outcomes. I'm sharing here a very early initiative that we launched, but I like to include it in all my presentations because it is so basic, it's so foundational, but it does highlight that ultimately the care that is being delivered will continue to be focused in primary care, and we need to make sure we enable our primary care colleagues to be able to appropriately diagnose and manage kidney disease and then refer to us as needed. So we created a chronic kidney disease checklist. We worked with primary care. We randomized it in a center that was interested in partnering with us, and we broke it down very simply. We actually inserted this checklist into any patient appointments that were coming up where the patient had the diagnosis of CKD, and we broke down, here are the steps that need to be taken to slow the progression of CKD. Here's what complications we need to be looking out for related to hemoglobin and bone mineral disease. And then very importantly, we said, here's when you need to refer to nephrology. These are the patients we really need to see. I didn't include the results here, but we did show that we were able to increase fairly significantly across all of these parameters, except for blood pressure control, which is not shocking. A checklist is not going to, in and of itself, help us control blood pressure. But across all the other domains, we were able to improve testing. We were able to improve counseling around NSAID use and referral to nephrology. We then evolved to creating a chronic kidney disease registry, where we now have a network-wide CKD registry of more than, now it's more than 70,000 patients. At that time, it was more than 60,000 patients, and captures data on key quality metrics, outcomes, key gaps in care delivery. This is important for a system like ours where we don't have a national registry, where we are limited to our network. We modeled this after the Cleveland Clinic, which was the first health system in the US to publish on a registry. But what we did is we added quality measures. And so you can see we added, how are we doing on annual testing for GFR and proteinuria, use of ACE and ARB, nephrotoxin use, hepatitis B immunity. And then based on that, we were able to, for example, for hepatitis B immunity, we launched a quality improvement project to really help improve our rates for patients with stage 4, stage 5 CKD. But you can see, for proteinuria rates, for example, how frankly woefully inadequate they have been. And this is unfortunately not dissimilar to other studies that have been published around proteinuria utilization. But this is the type of data that we've been able to use to facilitate improvements in quality and really to be able to share with our practices, with our providers in real time. Here's how we're doing. And so we've continued to maintain this registry. We've added components to it as well now, SGLT2 inhibitors. We published on that. We've also looked at advanced CKD opportunities, whether that be how often we're seeing a nephrologist, if patients have advanced CKD, are they getting an AVF or AVG placed? Do they have a referral to transplant? It was this type of data that then spurred us to launch our advanced CKD program, because despite messaging and despite partnering with providers and practices, it was not going to be enough to share the data and talk about workflow changes. We actually had to add resources, and that's what you'll see later in the talk. And so here were some of the takeaways as I've spoken to, whether it's proteinuria testing, ACE or ARB use, et cetera. And so having this registry management, being able to pull this data on a regular basis, really it can help spur improvements. And then I'll gloss over this just so that we can get to the latter part and then have time for question and answers. We did then use the registry to be able to answer questions that you probably were privy to. I know that the focus was really in the United States, but there ended up being a lot of discussion around COVID, around the time of COVID, 2019 to 2020, around the continued use of a race modifier in our CKD epi equation. And so we were actually able to use this registry to help answer questions about potential consequences of using the race modifier. And we were able to show, well, what would happen if we eliminated it? What would the impact be? Some thought, it would be really trivial. There would just be a few patients impacted. And we saw that, there would be about a third of patients who are African American who would be moved to a more severe CKD stage. And what we really focused on were the patients who moved from a GFR of greater than 20 to less than 20, because we were very curious about the impacts related to transplant, waitlisting, and referral. And that's where we saw that none of the patients who would have been shifted to a GFR less than 20, which is the cutoff that we use for referral, were sent for a referral for transplant. And so this raised a lot of concern about, well, what are the potential unintended consequences then of patients who aren't getting referred to in a timely way, especially when we know African Americans have a higher rate of progression to ESRD. So that was the conclusion. And then that led to the emergence of cystatin C, and we have been using that very rigorously here for the last 5 years. And then we had a national task force that I was part of that did lead to the revised equations that were published about 3 years ago that did remove race from GFR. We then modified our registry, as I mentioned, to include SGLT2 inhibitor prescription patterns. We were able to show that there were very low rates, not shockingly, of SGLT2 inhibitor utilization. This helped us engage with our federal government to say, as part of the Advancing Kidney Health Initiative, we need to keep an eye on SGLT2 inhibitor utilization, that this is really going to be able to improve outcomes, and we need to make sure that we're aggressive about the utilization of these medications. And this just shows, some of the details here about patients with diabetes, without diabetes, what the prescription rates were, what some of the barriers were. We outlined some of the barriers to not having proteinuria testing, for example, medication costs, to help us advocate for increased utilization. I'll go through a couple more initiatives and then I'll transition to the advanced CKD program. We realized very early on that if we were to truly be able to optimize the population, we needed to get smarter about who we were actually seeing in the clinics, because we have finite capacity. And so we ended up launching and now have really scaled, not just in nephrology, but across specialties, an electronic consultation program where and that we tested, that we looked at with both nephrologists and PCPs. And 96% of PCPs did feel that the e-consult results were effective and efficient. The most common conditions that we found were really lent themselves well to an e-consult were stage 3 CKD, medication issues, imaging issues. These were the types of referrals that we would be seeing in the clinic that would take up clinic capacity that limited our ability to be able to see those patients with more advanced disease. And so this has been a successful mechanism for us to be able to offload. And then this is just what the in-consult portal looks like in our EHR, which is a PCP refers, enters the e-consult question, then the nephrologist receives the e-consult within their in-basket. You can see it's a category, and then they're able to send back within the EHR very quickly after they do an assessment what they think the next steps are. And sometimes that does convert into an in-person visit, appropriately so, and that's fine. But this does help us create some efficiencies here in terms of who we see. We also implemented a nephrology referral clinical decision support. So for our PCPs, giving them guidance about a patient who should be referred. You can see last two eGFR separated by 90 days or less than 30. Consider referring to nephrology, and directs them right into that nephrology referral order set if they think that is efficient. We continue to collect data on this. The uptick has been slow, and so we've then implemented education around this with their PCPs, and we're considering randomizing this after an education effort to see if we can improve the rates. I think ultimately with a system like this, you need to have that real primary care buy-in, because there is so much that our primary care providers are managing that this becomes yet another thing that they're asked to respond to. So that gives you an overview. I tried to go through some of the high-level initiatives that we've implemented across the care delivery spectrum. And now I'm going to focus on the advanced CKD service that really was born out from our registry work, and then some of the real deficits we were seeing with advanced CKD patients. And finally, the work that's been happening nationally in our country around trying to spur increased utilization of home dialysis, improve optimal starts, really motivated us to create this program. So this program is a program that is meant to increase optimal starts, and the goal is initiating dialysis without inpatient admission and a catheter, improving vascular access, and increasing adoption of home dialysis. We were aiming to get to benchmark, which is 47 to 58% being at an optimal start. That doesn't mean 47, 58% on home dialysis. That means not getting admitted to start dialysis. And when we started this program, we were around 20%. And so a lot of opportunity for improvement. Phase one is around really, and we're still in phase one, increasing outpatient starts by leveraging CKD coordinators and a dedicated NP to see our patients and to see them with more frequency, because that was one of the issues that we had identified with our nephrologists, is that because our panels are so full, it is hard to see patients, particularly those who might be starting to progress very rapidly in a timely enough way. Our phase two, which we've started laying the groundwork for, is increasing access placement and maturation by having a more consistent way to facilitate vascular access placement, where right now we're very fragmented across our system. And then the third phase is a real intentional growth of home dialysis infrastructure. So actually expanding our home dialysis clinics, hiring more nurses. But before we did that, we knew that we had enough capacity in the home dialysis clinics if we were to be able to be successful with this phase one. And this just kind of articulates some of the rationale here around value-based care, around patient interviews. So we actually conducted very robust patient interviews, patients who had advanced CKD and were at risk for transitioning to dialysis, patients who were in that transition process, and then patients who recently transitioned, to understand what they were looking for related to the supports they needed related to education and navigation, et cetera. And then looking at our nephrology practices and their capacity. And then we were able to kind of model what we thought we'd be able to save the system and appreciated savings to justify investment here. And so this is what our operating model looks like. We have program manager, we have two CKD coordinators, we have a CKD NP, we have a part of a pharmacist time, we have a medical director's time. We meet regularly with our nephrology stakeholders who have clinical oversight. And then we started mid last year trying to roll this out in a couple of sites in our system, and now we're really scaling. Technology has been a critical aspect of this. So having that registry is critical to be able to see the patients who are stage 4, who are consistently stage 4, who are progressing. We utilize the KFRE score. We utilize progression, 30% reduction in GFR over the last 4 months. And then we leverage the EHR to engage with our patients, whether it's through education, care plans, WebEx. And then the Epic Comfort Shows platform is a platform we have within our EHR Epic that allows us to follow patients longitudinally. And so that's been really helpful for the coordinators. So our coordinators, we call them chronic care assistants. They're the ones who are reviewing the registry on a regular basis, and then they identify patients. They're the ones who are calling the patients. And these are individuals who have experience in the medical field, so they might have been medical assistants. Some of them are interested in going to nursing school. Some of them are even, young folks out of college who ultimately want to go to medical school but want to start in a role like this. So they're not trained clinically per se with the clinical licensing, but they're really invested in clinical care. And so they do the bulk of the work here as it relates to identifying patients who otherwise would fall through the cracks. Maybe they just got admitted to the hospital and their CKD worsened. They don't have an appointment with me for 6 months. Those are the types of patients that they're flagging and trying to get in with that nurse practitioner. They're spending a lot of time on education. For example, on home dialysis, getting the timing right, making sure that we're placing the catheter in the right time frame. And so that's a big part of what they own. And so they each support 150 patients. And right now we're at 200 patients in total. So they're each carrying a panel of about 100 patients. Then we have our nurse practitioner, and the nurse practitioner is providing both virtual and in-person care. The virtual care, because that means that she's able to support across the whole system, and then the in-person care for the patients who really need to come in because they're volume overloaded, they need a physical exam. Maybe I'm worried that my patient has early signs of uremia and I can't get them in, so the nurse practitioner will see them. And then also helps with education, knowing that we oftentimes will need more clinical expertise to provide education. And then there's a nephrology MD providing oversight. Then we have a pharmacist who really plays a critical role. They're doing a comprehensive medication review. And you all know, primary care is making changes, the cardiologist is making changes, endocrine is making changes. And so being able to have a review by a pharmacist who's trained in CKD and can help us with medication adjustments has been really helpful and really augmenting this work. And then they also assist with, for example, assistance with access for medications, which is an issue for us with SGLT2s. And then here are some of the operational metrics. You'll see this is still baseline data because we have not finalized our year 1 data yet, but we are seeing real improvements in optimal starts, which is encouraging. But you can see we look at inpatient starts, we look at outpatient starts, whether or not they use a CBC, what their hospital rates are, and then we look at various operational metrics, process measures like whether or not they were referred for transplant, etc. And then this is the registry and that the coordinators actually use and what they're looking at. So you can see, this is all fake data, but let's say I'm the nephrologist. When they last saw nephrology, when they're next seeing nephrology, what's their stage? What's their change in GFR? The 2-year ESRD score, that's their 2-year KFRE score. And so that helps us also prioritize patients. Did they have proteinuria screen? All of those measures are built into this that we can then use to help get labs on patients and also prioritize them in terms of coming in to see us. This is what the chronic care assistants use. I share this to say, like, I appreciate that you all are not going to adopt Epic anytime soon, but you can see here that this is a type of tracker that helps them follow patients longitudinally so that we don't have to rely on Excel spreadsheets. And this is all within our EHR now. So, for example, there are 4 cases that they're actively managing. They have X number of outreach tasks that they need to do. They need to call a patient. They need to ensure they have their refills. And so it really helps them keep all of this work organized, where otherwise it's really inefficient, and it's very challenging for the nephrologist to do this, and we really do need this type of support for more advanced patients. And I had one more slide here, but I'll just say this. I usually end with a lesson slide. I think, this work, and I'll say thank you to my division and the Department of Population Health at Mass General Brigham. I'll end with saying this, that, this work is challenging work to do because we're constantly asking our providers to think about how to improve efficiency, to think about delivering care in a different way, to help solve some of the clinical problems that we see on a consistent basis in a way that is systematized. And so some of the lessons here are, number one, always relying on the data, using the data as a real grounding force, because it is difficult to, change practices without having that data, and having that data on a recurrent basis is really critical. Second, it's constantly being able to bring it back to clinical care. It's part of why many reasons why I'm still an active clinician, but a big reason is because by being active clinically, I can constantly be able to bring those clinical examples back to the team and say, hey, I know we have this program in place, but it didn't work well here because we ran into a hurdle with anesthesiology. How do we do better next time? So staying active clinically. And then the last thing I'll highlight is publishing. You will see that almost all these initiatives we have published on, and it's hard to get some of these papers in because they are oftentimes not modeled with ideal study design, right? These aren't, we have a couple of studies that were randomized, but for the most part, these aren't randomized studies. We're basically doing what we can from a feasibility perspective, but without publishing, it's really hard to convince all of us who are very data driven and very data oriented to take a chance and implement a registry or implement a new EHR based tool. So those are some of the key lessons that I wanted to share. So let me pause there. Get some of the questions. Oh, you have Epic. Okay, great. That's great.
Yeah, I'll come to that later. We have some other questions, but we would like to understand how you guys used Epic, though we got Epic only a few years ago, way after Boston did. A naive question from a Canadian perspective, because I've never understood VBCs, is that from what you showed and what we have seen, VBC is basically paying the organization to do what you should be doing anyways, to do the right thing. And the value proposition to, because there's a lot of venture capital, private equity money that has flown into it, is that the government kicks back some of the presumed savings that happen down the road. Is that sort of in a nutshell?
You summarize it very well. So the reason that value-based care even needs to exist is that because we are a fee-for-service based country, regardless of payer, whether it's Medicare, whether it's even Medicaid, which is our basic kind of safety net program that's state-based, or commercial payers, all of us get paid. Like today, I have a clinic in a few minutes. I'm going to get paid based on how many patients I see. And so you can see how that may not align with clinical outcomes, because if you're only getting paid for volume, there's no element of quality. And so that's what VBC seeks to introduce is, wait a minute, we need a quality check here. The problem is that it has not been standardized across all fields, all elements of care. And so in our current structure, we actually opt in to participate. So like in primary care, we have a construct where primary care providers are holding financial risk. And you're right, we share any savings we appreciate with the government. So we keep some of those savings if we're able to save dollars and show that we're consistent on quality, and so does the government. But now what's happening is some of these mandatory models where the government is basically saying, you don't have a choice, like with their surgical conditions, you have to be in a value-based care arrangement with us. And the good news is MGB, if you do well, you're going to save money. But if you don't do well, you're going to actually have to pay us back dollars. And so it is forcing us to think very differently about how we track quality. And the last thing I'll say is this is tough for a lot of our providers, nephrologists for sure, but just across the board, because this isn't part of our training, right? Like this is how we measure quality, and so there ends up being, and we all know that metrics themselves are very limited just based on the definitions. And so there ends up often being a lot of back and forth of, argument about like, but what's in the denominator? What's in the exclusion criteria? And ultimately what CMS is saying is like, these are the metrics. You guys have to deal with it, and we're going to measure you against it. Yeah.
Cool. So if there are other questions, please put your hand up and ask them. You showed some of the results of that ESRD treatment choice looked pretty fascinating when it was announced, because it was
Yeah.
it was an RCT, right?
Yes. Yes.
But I remember seeing something in JAMA Health Forum a couple of years ago that it didn't
Yeah.
actually, if you look at
Yeah.
control versus intervention from that, not before, after, the effect was not that powerful. Am I?
You're exactly right. I did not mention that in the talk because I didn't think it would be as relevant to this group, but you're exactly right, which is so CMS said we're going to impose this mandatory model, but the only way we're going to be able to see if it's efficacious is if we randomize the country, because otherwise we won't have enough sample size to say that this actually worked or not. And so that model, so that the optional models were focused on advanced CKD optimal starts. That's still going. That is what I did share, which we saw an impact after the first year in some of these domains. But the ETC, the JAMA Health Forum, was the 1 year look back, but they just finalized a 3 year look back, and there has been no impact in comparing the intervention versus control. Meaning we saw increases in home dialysis in both cohorts. Now, the theory, though, I will say, is that our whole system has shifted in a way that ETC didn't account for. So what I mean by that is we've had a real growth in value-based care. We, just as you're saying, there are companies that have come in and they've said, we want to get into this. And so in the US, we have companies like Evergreen and Somatis. They're actually nephrology venture-backed companies that are saying, we want to work with plans and provider groups, and we want to improve home dialysis utilization because we know we can do well, like the plan can do well, and these companies can do well. So that was all happening in the background, and that was not accounted for in the analysis. So it's something that we've encouraged at the ASN to say, you need to include some sub-analyses looking at were these patients part of Medicare Advantage, for example, or at least for a period of time? Were they enrolled in any of these programs that have evolved over the last 3 years? So I think there was a lot of confounding, even though it was randomized. Yeah.
It's hard to show a difference at
Yeah.
such a large scale. Dr. Karpinski.
Hi, just checking my voice works. Okay, because I did
Yes.
that yesterday in a meeting. Great, thank you. So just a couple of practical questions. When you say e-consult, we do them two different ways. We do them where we actually do a telehealth visit with the patient, whether it's Zoom or another technology, but we also do them where we're just really providing the opinion back to the physician without seeing the patient. So I would just, if you could clarify that. And then my second question is, I'm really interested in these chronic care assistants that you have, because helping our patients, never mind us, navigating this complex system is so helpful. I was just curious how you train them, how long it takes to train them, and what kind of turnover you see in terms of those individuals. So if you could answer those two.
Yeah, great question. So relate to the first, I'm really talking about the latter, which is it's an opinion based. So we do it all within Epic, and we say, and we have a disclaimer that we reviewed with legal, and to say this is just an opinion. Ultimately, it is up to the discretion of the primary care provider about whether or not to follow this recommendation, which is why we did that study looking at their satisfaction with the e-consults, because ultimately, they are taking that on, the PCPs, and have to be satisfied with the program. But they've been really happy with it because, they're patients, they don't want them to wait 6 months to get an answer about, imaging. And it sounds like you all are using a program like that. Um, in terms of our chronic care assistants, so we put them through a very rigorous 6 weeks. We call it an academy. We actually have chronic care assistants that we utilize for heart failure, for primary care. It's broader actually than CKD, that role. And we invest a lot in them. We pay them very well, just to get tactical. We pay them very well. We train them well. We make sure they really feel like they're part of the team, right? Like I actually emphasize that to everybody. Like, yes, they don't have a clinical license, but they're adding tremendous value to the team so that all our clinical folks can work top of license. And so far, we have not had a high amount of turnover, but it's not dissimilar, for example, from like, what I talk to colleagues who have nephrology private practices. They invest very heavily in their medical assistants because they know that ensuring a limited turnover is really going to help all their clinical team members. And so if you all have any interest, I'm happy to set up time actually with our advanced EKD program leads and the chronic care assistants for you to learn a little bit more about what they do if that's of interest. Yeah.
Thank you. Thanks for that offer too. Manish.
Uh, Thank you very much, Dr. Mendu, for your talk. Very interesting. It um, it's interesting hearing this perspective as a Canadian because
Yeah.
we have um, essentially implemented a lot of what you are going through, the battles you're fighting, maybe is a way to say it,
Yeah.
at
Yeah.
provincial levels for over some 20 years. So, for example,
Mhm.
BC has like a lot of that stuff has been going for over 20 years.
Right.
Ontario, we've been doing it for at least over 10 and even 15 years.
Right.
So we've gone through some of these wars,
Yeah.
as to say, like standardizing criteria, referral criteria, reaching out to the primary care, collecting analytics. One
Yeah.
piece I would say, and we also have home dialysis prevalence of 25% for 30 or 40 years as well.
Yeah.
So one thing, just for a policy, because it does seem you have a lot of policy work, especially at the national level. I would say look to potentially involve Canadians because the
Yeah.
literature itself doesn't always tell you stuff. But
Yeah.
there's a lot of policy things. I think here it's a reverse situation maybe where the U.S. could learn from Canada.
Yeah.
We've been primary prevention driven for a
Yeah.
long time. I'll give you
It's a
examples.
brilliant idea. Yeah.
Yeah, so like we have a lot of these implementations for care, and we've had some of these natural experiments go through. I'll give you one example is we in Ontario about 15 plus years ago, we equalized reimbursement for PD2 hemo. Hemo was higher. And so the
That's it.
idea
I
was by
remember
doing
that.
this, are you going to see a
Yeah.
financial incentivization to move more people to PD? And
Yeah.
nothing happened.
Yeah. Yeah.
So I just thought that was really fascinating. Like,
It is.
you
Yeah.
could see where the drivers maybe are or maybe aren't. Maybe it gets saturated at a certain point. Maybe it
Yeah.
doesn't. Another point is a lot of your within nephrology MCK referrals were GFR based,
Mm.
which I found fascinating. Here we are in a lot of provinces doing KFRA based. So
Mhm.
risk-based care, where the referral is based on if you are 10% or greater, you then advance to the
Mhm.
multifaceted team, and we think about your access and et cetera. I think there's
Yeah.
good evidence for that as well. And I just as a friendly idea, just put it out there to
Yeah.
consider and to look into. We have a lot of experience in that now, and we're actually reimbursed based on KFRE risk referrals. The
Oh,
third one,
really?
yeah, yeah,
Wow.
yeah.
That's
It's
really
just an
interesting.
idea. I'm just putting out there, and I
Yeah.
and I appreciate the war you are at. I call it a war because you're like changing your center. And then you
Yeah.
have to go and get every other center to change, where we've at least had the benefit in Canada where most dialysis centers are part of provincial programs. and we can control everything between 3 or 4 nodes. 3 or 4 groups can change the entire province's care. So I
Yeah.
appreciate the battle you're fighting, but there are some good lessons to learn. The last one was the race-based stuff.
Yeah.
And we've been involved. We did the race stuff for adaptation here as well. And that was very challenging because I view it as a fundamentally US issue. Now, it doesn't mean that racism and stuff doesn't exist outside, but the identifier of Black race and the implications behind it, I don't know if they apply when you leave the US. So, for example, our Black population is about 4%, and it's mostly Caribbean immigrant,
Yeah. Yeah.
first generation or second generation. So it's very difficult to be like, well, should we make this adjustment because the non Black population then get the GFR increase, like the error goes in the opposite direction.
Mhm. Yeah.
So these have been very fascinating battles or issues that we've been trying to look at. And I
Yeah.
know the EGFR one was very controversial because it was created with a bit of maybe a US centric lens, but
I know.
that then goes out to the rest of the world. And like I know in Europe, they're like now thinking of not even going to use the CKD-EP equation anymore, and they're moving to
I
the
know.
EKFC because of
I know.
these
Yeah.
misclassification issues. Anyway, this is just fascinating
Mhm.
discussion and a great presentation.
Thank you. It's great. Lots for me to mull over. This is great.
Thank
Yeah.
you. If you can have one last question, Dr. Noel.
All right. I was waiting for Manish to ask a question, but he was just talking there. So my question might be a little less rosy than Dr. Sud's. So just to ground everyone. So we are in a regional system, but we also operate out of one main hospital. That hospital right now has $100 million operating deficit. So there's a hiring freeze on everybody, and there will likely be massive cuts coming to our care programs, even nephrology. I'm looking at Dr. Karpinski, not going to be exempt maybe. So all these programs require an upfront investment. Like you need to hire these NPs, you need these CCAs and things. And so for us at a level to get anything like that organized, or even get the ear of anyone at this kind of financial situation we're in, is we have to be able to show some long-term data that in a like what you're doing in a population setting actually works and saves money. So I'm wondering if there are other examples, for example, in diabetes or heart failure or COPD, where they've studied true like regional captures and regional populations the way we work, and that can show that these systems of care actually work, which is really what you're trying to do. Because for us, it's all the battle is the upfront investment to actually get funded.
Yeah. We've published quite a bit on primary care coordination and the impact that has had on cost, and I'm happy to send that to you. It is a different model than nephrology, and it's why we are actually randomizing, I didn't mention this, but we're randomizing that advanced CKD program because one, we have too many patients, we can't see all of them, and two, to get an answer just like this, to be able to say we did save costs in the short term, in the long. For us, it's easier to make the argument because when we're in these ACO models and we are able to say, hey, we're able to avoid this admission, that's a $10,000 savings that we're able to then point back to CMS and say, for every patient we avoid crashing into dialysis, we're able to save $10,000. So that's the type of analysis that is easy for us to do. I imagine it's harder for all of you to do, but I am optimistic that because of our recruitment into this program, that we should be able to have some pretty robust data by the end of this year in terms of what our randomized efforts have yielded. And then again, that is why, I really push people to publish. And if you look at my bibliography, you'll see like some of these studies are like pretty atypical, but it's important, because otherwise we don't have anything to point to when we try to do this type of work.
And are there other, like in, for example, COPD or heart failure, are there other population healthcare models that you're aware of?
Yeah.
That have positive
There are heart failure care management programs. The COPD literature is more scant, but there definitely is a literature in heart failure. So I can send you, not that we published ourselves, but some references that we refer to when, for example, we built our heart failure program. Yeah.
Okay, thank you.
Yeah.
Thank you. If you have time, can I ask one last question about Epic? Because we are
Yes.
way behind you on Epic.
Yeah.
How
Yeah.
is it to build those? Is it like a dashboard that you were showing?
So the registry functionality, so Epic actually has a CKD registry that you can get out of the box. It's not great though. So we created our own registry. But the logic is not that complicated to create. And we published on this in CJSON. So like we were very transparent with here's the logic we use. So I would say you could either look at the out of the box registry, look at our code and our language and see if that's something that you're interested in. And then I'd say that dashboard that I shared, that is part of Epic Compass Rose, which is a population health based platform. So it is worth asking your digital colleagues about that because you can get that through Epic Wisconsin. There is investment in that tool. You know, we've had to invest in it. I don't know if the rates would be any different for folks in Canada. So, but also happy to set up additional time, honestly, to go through that, to go through the chronic care assistance. If any of that is helpful, happy to do so.
Awesome. Yeah, thank you for those suggestions. And again, thank you for presenting to us on this topic. I hope there'll be more collaborations and things we can learn
Yeah,
from.
we'll love that. Yeah.
Thank you.
Thanks all for the time. Appreciate it. Take care. Bye.